The healthcare environment right now is very defined and has been for a long time by the state of the American healthcare system. And what we know from the Commonwealth Fund and from other researchers of the state of American healthcare is that the American health system is both the most expensive of any developed nation and also has the poorest health outcomes. And that's something really that has been the folks in think tanks and in the federal government have been trying to fix for the last 7 or 8 years. And what came out of that was something called the triple aim. And the triple aim really has 3 legs. It has population health, in other words, improving people's health in measurable ways. The second piece is patient satisfaction. Are patients happy with the services they're getting? And the third piece is cost effectiveness. Are treatments being delivered not only effective, but also cost effective? And so really the whole health system has been moving toward the triple aim and trying to accomplish the triple aim for the last 7 or 8 years. And the goals of that are very consistent with the landscape for American healthcare. Now, group therapy has a very unique contribution to this because there are so many efficiencies it offers. There are so many ways it offers effective treatment, and patients tend to be very satisfied with the treatment model. So again, it really has a very important role to play in really changing that landscape and in becoming a key element of reform and improvement in American healthcare. Mental health is currently the most expensive part of healthcare in America right now. So AHRQ, which is a leading collector of healthcare statistics, in 2015 released their list of top medical conditions, which includes things like diabetes, COPD, heart issues, and mental health is now number 1. And there are many reasons for that. Partly it's to do with a recognition of the prevalence, but it's also to do with how the way that mental health treatment is delivered has changed. In that medication is now used extensively to treat mental health conditions. And while there's a place for medication, and sometimes an extremely important place, applying that without thought can be very expensive. So, for example, treating somebody who's depressed with mild to moderate depression with antidepressants for 10 years is prohibitively expensive. That might be, $30,000, $40,000, $50,000 across a lifetime. And in some cases, people literally take that medication their whole life. And that is an extremely expensive way of treating depression. Now, by contrast, the research literature says if you treat depression with therapy, as long as it's in the mild to moderate range, you're likely to have very effective outcomes in a shorter space of time at less cost. And group is an evidence-based means of treating depression. So really a lot of the mental health cost is because the treatment is not efficient and it's not thoughtful. And again, the role of outpatient therapy and inpatient therapy has a significant role to play. Again, look at the contrast where emergency department visits are between $7,000 and $15,000 a visit. And if it's for mental health, and again, a lot of emergency department visits are related to mental health and substance abuse, that is a huge expense. Now, if you can treat those folks in an outpatient setting or have them get therapy that helps them maintain so they stay out of the emergency department, again, you can provide effective treatment that is less traumatizing for that person, so they're more satisfied with it, it's more cost effective, and the outcomes are superior. So really, again, group therapy has an extremely important part to play in controlling costs, providing efficient treatment, effective treatment, and having satisfied patients. Now, cost offset is something that is, and comorbidity are very important issues in healthcare. So basically, comorbidity is the idea that if you have diabetes and depression, that's called comorbid. Now, if you have diabetes with depression or heart disease with depression, what the research has found is it adds another $746 per person per month to the cost of treatment. So comorbidity is extremely important. So what we know is that a very small percentage of patients account for a huge percentage of cost. And of those small number, there is a very significant number of those folks have an involved mental health condition. So by treating that mental health condition, you're actually helping bring down the overall cost of care for that person. So here's an example. If somebody has diabetes and they're depressed, okay, depression can affect our ability to want to go out and exercise. It can affect our volition. In other words, we're less inclined to want to try and do new things. And again, a lot of the way to control diabetes is through eating, is through exercise, is through medication management. So if you have an involved depression with that, it's much harder to do the things that will help you get better. So again, that can turn from being that can turn into becoming something very chronic and very severe. And that's not only distressing for the patient for their diabetes to worsen, but it also becomes extremely expensive for a health system to manage. So really treating that depression as part of that medical condition is an extremely important piece. And again, there are several different ways group can contribute to that, ranging from diabetes groups that treat the medical condition to depression groups that you can refer people with medical conditions to, and even to what you're seeing now, shared medical appointments in doctors' offices, where the physician and a psychotherapist will talk to patients together, and they'll address the whole diabetes, depression, or whatever involved medical condition there is together. And again, so the outcome for that is better for everybody. And group really has an important piece to play for that. So outcome measures for group therapy are extremely important because they prove that group therapy works. And we already know from the literature that group therapy is effective. But it's very important that group therapists really understand that at a local level, this is just as important as somebody doing a study in a university. Because you need to be able to understand your outcomes and to see where, if somebody's starting to deteriorate, how do I catch that to get them back on the right trajectory? When they have improved, how do I show that to an insurer? How do I show that to the patient? And say, look how well you've done. So there are many pieces, I think, to outcome assessment. And we know that group works. I think the question really now is, let's continue to show that group works and prove that both nationally and locally, and really have practitioners embrace that local outcome assessment is just as important. And that insurers, for example, are really eager to see how are your outcomes going. We know it works, it's just a question of proving it and showing it. So I think the outcome piece is extremely important, and there are empirically validated measures that will capture that outcome well, that are electronically administered, that will collate that information in ways that are useful for the client to see, useful for the patient to see, and can also be thoughtfully given to an insurer after they've been de-identified. So, for example, the OQ measures system has a wonderful electronic interface and will show individual outcomes for each client and group outcomes and outcomes for the practice as a whole. So it's a very, I think, elegant way and way that's consistent with the way that healthcare is moving is towards an integration of electronic data. And that really is going to be the future, and I think the future for group is very bright, because as those electronic means of measuring outcomes become more solidified within routine practice, it will be easier for group therapists to show what they know. The other piece of outcomes that, again, we don't really talk a lot about as therapists, but are equally important, are showing things like time to readmission, ED visits, and a range of other outcomes like lifetime cost of care. So, for example, ED visits. Again, as I've said before, if one ED visit is $7,000 to $10,000 or more, and your client has had 10, 12 ED visits in the past year before they came in for treatment, and since they've been in treatment in the past year they've had one ED visit, you've saved hundreds of thousands of dollars for that insurance company, while at the same time helping the patient avoid a very distressing event. And that's something that we should be much more enthusiastic and much more diligent about reporting and showing people, because that's an important part of cost containment. And it speaks to the triple aim. We're treating people, they're getting better, and we're saving money, and patients are more satisfied, and that's very important. So recent research summaries of group therapy have been very positive about the impact of group therapy. It's found that groups are typically very, very effective across setting, across population, and across diagnosis. It's also found that they have, on aggregate, comparative effectiveness to individual therapy. But again, as groups, they are very efficient. You're seeing more people in a shorter space of time. So again, it has a significant amount to offer in terms of the provision of therapy. And there is an impact from people being in groups with similar conditions, with similar presenting problems, that again, they get an impact not just from the therapist, but they also get an impact from the other group members. So we know there's a lot going on that are directly related to the power of group. Again, the research evidence has been good to excellent for a range of different diagnoses: depression, anxiety, social anxiety, panic disorder, eating disorders, addictions, schizophrenia, and a wide range of other diagnostic conditions. So what we know is for the whether it's things that are comorbid to a health condition, whether it's chronic and severe mental illness, which again, back to the idea of cost, are extraordinarily expensive without treatment, that there is a robust and clear impact of group therapy that's been demonstrated by the research. So given we don't really know politically what's going to change about healthcare and healthcare policy, I think in my ideal world, having worked in a very large hospital system and seen what makes an actual difference in patients' lives, the continuation of the triple aim, which says, we need to measure outcome, we need to focus on people getting better in concrete ways, the use of patient satisfaction as a continued measure, the use of metrics to capture cost effectiveness, and to continue thinking about how do we deliver services in an efficient way, but in a way that improves outcomes, that really says, okay, let's make some changes and test that and see how that works. And then also having a payment system that aligns with those better systems. So again, looking at the bundle payments initiatives that go through were going through CMS. Those kind of things that really provided, I think, a fantastic window into how healthcare could be and can be. And again, I think what you saw was a lot of optimism amongst CEOs of hospitals saying this is improving the care we're providing. So anything that can continue that can keep that focus on those simultaneous aims, and that can continue to measure and test and compare, is really the way forward for the American health system. Not all of those things worked out perfectly, but a lot of learning happened when they didn't. And the ones that did really were beacons of light that showed the future for American healthcare. And again, it is possible to control cost. It is possible for American healthcare to improve, particularly with more upstream interventions around prevention, with around more thoughtful concentration on where the most efficacious treatments are, and in a way that sees treatment as holistic. It's the whole person, that it's not just the physician controlling everything, but that there are people involved at all levels of care, whether that's the dentist with oral hygiene, which can impact heart health. A recent study came out that showed depression can actually increase the risk for heart attack. So we need to understand the role of different healthcare providers in the American health system as all having a piece to contribute to American health. Again, I saw a recent interview with a leading physician who said, we need to think of physicians not as the race car driver, but as members of the pit crew, that we're all working together. The psychologist is working with the dentist, is working with the physician, is working with the nutritionist, and we're thinking about people holistically, because in the long run, that's what will increase and improve the health of the nation and control costs. And as long as we can focus on that final outcome and let go of the idea that, oh no, we need to control costs by removing the nutritionist, removing mental health, then we're truly going to get a hold of the cost and the outcomes. So that's where we need to keep our focus.